real life.
Hello everyone and welcome to a yet another meeting of Journal Club meeting, the MOS BOA joint venture season 4. And today we have a very interesting topic about infectious keratitis post C3R, and we have a very good faculty today discussing the same. And I would invite the MOS president to Sirish Thorat sir to open the meeting for us. Thorat sir.
Yes, thank you, Vaishal sir, and good evening all. On behalf of MOS, I welcome you all to this MOS BOA Journal Club meetings. A big thank you to all Journal Club team for bringing all these stalwarts together on such an important topic of infectious keratitis post C3R. As you know, C3R has been a game changer for so many patients of keratoconus. However, even if the best treatment can have complications, infection after C3R, though rare, can be very serious. That's why we need to understand the risk factors, the causes, and most importantly, the management protocol. And I'm sure tonight's meeting will strengthen our knowledge in this regard. My heartfelt gratitude to all faculties, Dr. Prashant Garg sir, Dr. Shweta Agrawal madam, and our own Dr. Sangeeta Wagh madam for sparing their valuable time. Actually, many of us have learned cornea from all three of them. As far as students' clinical activities are concerned, a team of Lata Mangeshkar Medical College, Nagpur is always on the forefront. A big thank to HOD Dr. Rekha Khandal madam, today's moderator Deepa Kumar madam, and my best wishes to today's presenter Dr. Ashwini. So, without much ado, I'll hand over the proceedings to Vaishal sir. Over to Vaishal.
The BOA president has not joined, so we take it forward and ask Dr. Parul Deshpande to please introduce our esteemed faculty today.
Hi everyone. So I'm Dr. Parul Deshpande. I'll be co-moderating the session with Drs. Neeraj, Dr. Deepa. So our esteemed panelists, so we all know Dr. Prashant Garg. He is Executive Chair LVPI, and his main interests includes the corneal infections, the antimicrobial resistance, and corneal transplants and eye banking. So welcome Dr. Prashant Garg to our Journal Club session. Our next panelist is Dr. Shweta Agrawal, who is one of the CEO of Ocular Surface from Shankar Netralaya. She's a senior professor there and has been handling all the ocular surface problems. Our third panelist is Dr. Sangeeta Wagh, who is heading Wagh Eye Clinic at Pune, and she's one of the esteemed corneal private practitioner. I would say has a huge volume of corneal practice in Pune. So welcome Dr. Sangeeta, who's been doing a very good corneal practice in the private setup. So with all of them, I would now welcome our presenter, Dr. Ashwini, to present her Journal Club article. So Dr. Ashwini, are you there?
Good evening, ma'am.
Yeah. So you can share your slides.
Yes, ma'am.
Yeah. So I think before we start, I just wanted to say this article actually is from Chennai only, the SN group. And we're sorry that we could not get Dr. Meena Lakshmipati. I think she's she's one of the main author and behind this landmark article, I would say. So I think we are grateful to her, but we are sorry that we could not have it here in our panel. Yes, Ashwini.
Should I start, ma'am?
Yeah, you can start.
Good evening, all. First of all, I would like to thank you, BOA and MOS committee, and my coordinators and my moderators, and all the panelists here for giving me the great opportunity to present the Journal Club today. Here I am presenting the study done by Dr. Meena Lakshmipati in Shankara Netralaya, Chennai on incidence and outcomes of infectious keratitis after collagen cross-linking over 10 years from the tertiary care center in South India. Introduction: corneal collagen cross-linking is a standard treatment for progressive keratoconus where epithelium of technique increases the risk of infectious keratitis, which is rare but potentially life-threatening. My objective is to determine the incidence, microbiological profile, and outcomes of infectious keratitis after collagen cross-linking over 10 years at the tertiary eye hospital in South India. Methods. It is a retrospective study done from January 2011 to December 2020 in eye clinic of tertiary referral hospital in South India, identified from electronic medical record system using ICD-10 coding. Methods, inclusion criteria, patient who underwent collagen cross-linking for progressive keratoconus who developed infectious keratitis within 1 month for both in-house and referred patients. Patients with presumed viral keratitis were excluded. Information noted from the case files was age at the time of collagen cross-linking, sex, laterality, status of the fellow eye, indication for collagen cross-linking, type of collagen cross-linking, preoperative pachymetry, preoperative regurgitation on pressure over the lacrimal sac test, best corrected visual acuity at the time of presentation, resolution of the infection and at the time of the last follow-up. Ocular and systemic risk factors, nature and duration of the presenting symptoms, characteristics of the corneal ulcer, microbiological culture and sensitivity. Preoperative protocol included an antibiotic prophylaxis such as moxifloxacin eye drops were used 4 times a day before surgery for in-house patients. No data was found for preoperative prophylaxis for referred patients. A collagen cross-linking procedure. All procedure underwent epithelium off procedure. 3 of them underwent isotonic collagen cross-linking and 6 of them underwent hypotonic collagen cross-linking, those whose pachymetry was less than 400 micron meter. UV radiation dose was 5.4 joule per centimeter square with energy 9 milliwatt per centimeter square for 10 minutes. A bandage contact lens was applied post-operatively and corticosteroids and antibiotic given in tapering dose. Infectious keratitis workup. When we suspected, corneal scraping were taken immediately. Microbiological processing was done with gram stain, 10% KOH, calcofluor white, culture media like blood agar, chocolate agar, PDA, thioglycolate, and BHI broth. Criteria for significant culture was growth on one or more than one solid media, confluent growth at inoculation site, culture correlating with smear morphology. Antibiotic sensitive was performed using Kirby-Bohr disk diffusion, management customized based on antibiogram. Data analysis was done by startup 12.1. Interferential statistics could not be done due to small sample size. Total collagen cross-linking procedures were done on 3,842 eyes. Post-collagen cross-linking infectious keratitis were found in 11 eyes, out of which in-house cases were 8 and referred cases were 3. Mean age was 21.8. 7 were males and 4 were females. 8 were left eyes and 3 were right eyes. Collagen cross-linking was done for 10 eyes who had keratoconus and for 1 eye who had post-LASIK ectasia. Risk factors were allergic conjunctivitis, contact lens wearers, vernal keratoconjunctivitis. 5 eyes had hypotonic collagen cross-linking whose pachymetry was less than 400 micron meter. The median onset of infectious keratitis was 3 days post-collagen cross-linking and hypopyon presented in 6 out of 11 eyes. Culture result shows 4 methicillin sensitive Staphylococcus aureus, 4 methicillin sensitive Staphylococcus epidermis, Aspergillus fumigatus, Aspergillus flavus, 1 Haemophilus parainfluenza, and no growth on 2 culture media. Discussion. Post-collagen cross-linking infectious keratitis is rare complication occurring in 3 per 1,000 cases in present study. Infectious keratitis after collagen cross-linking is rare, that is incident was 0.21% but potentially vision threatening. Most infections occurred within 3 to 4 days post-procedure, mainly caused by methicillin sensitive Staphylococcus aureus with notable fluoroquinolone resistance. Patients responded well to topical antibiotics guided by culture and sensitivity with good visual outcomes, more than 6 by 18 despite of residual scarring. A few required surgical intervention, that is keratoplasty or globicial. The study emphasizes the need for early diagnosis, culture-based treatment and possibly revising antibiotic prophylaxis due to rising resistance. Although limited by small sample size, the findings are clinically relevant for improving post-collagen cross-linking care. According to the Mari criteria, the method study question was well defined, sample size is adequate, sample size, study population, inclusion and exclusion criteria is well defined, study period is well defined, and it was a retrospective study. Assignment: retrospective grouping was based on infection occurrence post collagen cross-linking, grouped by type of collagen cross-linking, organism identified, and treatment modality. Assessment: outcome measures are depending on microbiological spectrum, antibiotic resistance, clinical outcomes like vision, need for keratoplastin glue, and complications. Assessment methods: cornea scraping for culture sensitivity, use of standard microbiological techniques like gram stain, KOH mount, and culture on various media, antibiotic sensitivity by Kerbev or disc diffusion, visual acuity follow-up, and median follow-up period was 24 months. Statistical test was appropriate for given sample size. Interpretation: post-collagen cross-linking infectious keratitis is rare but serious. Antibiotic resistance is a key concern. Extrapolation: infectious keratitis after collagen cross-linking is rare but clinically significant. Majority present within 3 to 5 days of post-op, mostly affected with commensal bacteria like methicillin-sensitive Staphylococcus aureus or methicillin-sensitive Staphylococcus epidermis. Many isolates were resistant to ciprofloxacin, so that considering alternative antibiotics. So there is need to change the antibiotic regimen. All patients received topical steroids from post-op day 1 can be the another risk factors. Most eyes recover well with the topical antibiotic. 36% required glue or therapeutic penetrating keratoplasty. Pre-op and post-op blood glucose level should be checked to prevent the risk of infection. My interpretation is the study highlights the need to review prophylactic antibiotic use post-collagen cross-linking due to rising resistance, especially in tropical regions. Post-collagen cross-linking infections are rare but sight-threatening and appear mostly in the post-op first week period. More than 50% of infections caused by bacteria originate from the eyelids. Therefore, special attention must be given to the eyelid hygiene. During surgery, it is essential to properly drape the surgical field and perform an eye wash with 5% povidone iodine. These steps are crucial to reduce the risk of infection. It is important to ensure the strict adherence to these precautions. Awareness, early detection, and choosing antibiotics based on the local resistance patterns can ensure the good outcomes. Thank you, sir.
Ashwini, do you have the table where they are talking about the clinical presentation and the outcome?
Yes.
Okay. Yeah. Okay. Not this one. The other one which they have discussed about the previous one. Okay. Did you discuss this table here, Ashwini? Yes. What
Yes.
it is? Okay. Yeah. So I think I missed it. Okay. Thanks, Ashwini, for the wonderful presentation.
Thank you, ma'am.
And with this, we can take it forward to our panelists. So I think first we'll go to Dr. Prashant Garg, who can tell us about the infection, about this article. So Dr. Prashant.
No, I think this is a very good series, um, particularly keeping in view that it is a relatively rare complication following collagen cross-linking. If we look at typically how collagen cross-linking is performed, we realize there are multiple risk factors that are associated with the procedure of collagen cross-linking. The first is you have a large epithelial defect, so there is no epithelial barrier. Number two, the eye remain exposed in the conventional Dressadan protocol for almost 40-45 minutes when you are performing the procedure. Third, riboflavin is a drug, although it should be typically dispensed as a sterile, but there is a vulnerability that if there is a contamination that you are soaking cornea for a long period of time. And then lastly, the bandage contact lens that you are applying. Despite multiple risk factor, I think it is very well known that collagen cross-linking is relatively safe procedure. So keeping in view any study that has described a series of 11 cases is really a commendable effort by the authors in bringing out this large series to give us all a perspective of what the clinical picture in these patients is and how which organisms are more common and then how do you manage these cases. The challenge in these cases is that while the authors have picked up all microbiology proven cases of infectious keratitis, what we have observed in our practice is that there are substantial number of cases who presents with infiltrate that is indistinguishable from infectious keratitis, but they are culture negative. Giving antibiotic in those situations lead to worsening of the infiltrate. The two cases they had were microbiology negative, but fortunately both of them resolved. One had Haemophilus parainfluenzae, but I think even that case uh, we will consider that possibly might not have been infective. But they are very fortunate that both the cases which were otherwise sterile, they resolved as well. I think this article would have given more insight if the authors would have included all patients presenting with infiltrative keratitis. Then you would have a culture negative enough volume such that you could have got enough idea about what are the distinguishing feature between sterile and non-sterile keratitis. So that's one thing that I noticed. The second thing is that there two cases required collagen cross-linking, and when I read the article, both the cases were in-house. They presented at a short duration after the onset of infection. However, what led to the worsening of despite these being in-house cases? And I think that would have been a good insight for readers to know uh, what are different factors that result in worsening of clinical picture. As far as antibiotic susceptibility data is concerned, while the authors have commented on that most of these cases are caused by staph or gram-positive organism, it is very well known that gram-positive organisms have relatively poor susceptibility to ciprofloxacin. And therefore, this should not be the antibiotic of choice. Number two, moxifloxacin. While this is used extensively, we are seeing that almost 60% of all isolates, I'm talking about gram-positive, are already acquiring resistance. After reviewing data at our center, what we have started is we have switched over from fluoroquinolones to a combination of chloramphenicol with polymyxin B, and that gives us a good coverage as far as prophylaxis is concerned. So I think we can take this data, this result uh, that when we are dealing with the post-surgery infectious keratitis, rather than starting treatment with fluoroquinolone, I think it is better we start treatment with either fortified antibiotic or antibiotics that are currently effective against gram-positive organisms. I think the last point that I will like to make on this article is the prevalence of gram-positive organism in this series. And I think this very clearly highlights that most of these organisms that cause post C3R originates from the adnexa, and therefore one should be extremely careful uh, in ensuring appropriate draping, povidone iodine conjunctival cul-de-sac, as well as lid prophylaxis. such that you can reduce further the chances of infection. I think one additional point or one additional thought that I have is, while we say the gram-positive organisms are very common, we have seen cases which are originating from contaminated contact lenses or contaminated solution, and those cases are predominantly caused by gram-negative organisms. So while gram-positive organisms are very common, one should not neglect that some of these cases can be caused by gram-negative organism, and therefore the initial treatment should be a broad spectrum antibiotic, although you may see gram-positive organisms on the smear or gram-variable organism. We always advocate that in case suspected of microbial keratitis, following surgical procedure, including C3R, start treatment with drugs which cover for gram-positive and gram-negative organism. So I'll stop here.
So one question, what about the use of steroids post-op? Should we have...
See, following collagen cross-linking, the typical regimens are that you give antibiotic but also give corticosteroid. And the rationale for corticosteroid is that a procedure where you have denuded epithelium, the injury to epithelium itself induces inflammation. If you do not start corticosteroid in patients who are undergoing procedure under aseptic conditions, you possibly will see some infiltration in those cornea with the resultant scarring. And that may be a concern, because then you will confuse this case with whether this is an early infection or not. And we have seen that the inflammation degree varies based on the individual, and also those who have allergy as a predisposing factor for keratoconus, you see much more inflammation in those eyes. So corticosteroid is a preferred way of antibiotic with corticosteroid is a preferred way of post-operatively managing these cases. Keeping in view such a rarity of infection, I would not advocate or I would not make judgment that those who are using steroid are doing anything wrong. So we do not have any justification of saying, oh, steroid should not be given. You can start steroid. However, there is a second school of management in these cases. Some say that only when we see epithelial healing has started, that we will start steroid. And I think they are also right in delaying starting steroid for say another 2-3 days, and only when you are seeing some epithelial healing, you can start steroid. Both the practices are common in clinical scenario.
Dr. Shweta, being a co-publisher, I would like your opinion and also the choice of steroid that you would prefer to use in post-C3R cases as a treatment modality.
Thanks, Dr. Parul. So first of all, a huge credit to Dr. Meena. She is the primary author of this paper, and the entire work and the entire credit of the paper, we would all give it to her because it was her hard work. We're all co-authors putting in our tidbits in between, but she was the main architect of the paper. Actually, Dr. Prashant has highlighted some very beautiful points. And before I answer your question, Parul, I would just continue the discussion that Dr. Prashant started with 2 in-house patients requiring a therapeutic graft. In fact, I was the opening batsman for that first patient. And in fact, that first patient was the first patient in our series who developed an infection. And, like your first baby, you can never forget. So it was like that, my early days of consultancy. This is way back in 2010. And appeared after the epithelial defect had healed, and it was to begin with a posterior small whitish dot on the endothelium. And that picture is still very fresh in my eyes. The defect had epithelized. I had removed the BCL. So, you are very, your first few patients, you're very careful and passionate about them. So I have been following him up every day. He was doing fine. Local patient, absolutely good. Removed the BCL, defect healed. 2 days after the defect healed, he comes to the clinic with a drop in vision. There was a little cellularity, not much, with a white dot on the endothelium. And we could not, in our wildest dreams, imagine that this was an infection. I remember showing this patient to Dr. PP because she was our department head and the senior most person with the most years of experience. Almost every cornea consultant in our department had seen that patient because we really didn't know what we were dealing with. Eventually, we hiked up the steroids because it was an endothelial dot, no defect. We could not think of an infection. But when that infiltrate started increasing, initial scrapings, everything negative. Confocal is not showing anything. It's showing only inflammatory cells. And finally, on the day 5 or day 6, when the infiltrate really enlarged, the scraping did show some gram-positive foci, and that is how we realized that it is MSSA. And it just worsened in front of our eyes, and we had to take him up for a therapy. So that was, as I said, I was the opening batsman for that. And it was very difficult for us to identify or even doubt that it was an infection because it was post-healing of the epithelial defect. All our patients are operated in the refractory surgery unit. We have a CXL table. So they are all draped properly, like you drape any of your refractive surgery. A povidone drop of iodine is put in the eye. And we were all using bandage contact lens with a post-operative antibiotic cover. So this series actually brought into highlight that the commensals are the ones who become the culprits, and the infiltrates, which were larger in size, were the ones which required a glue BCL or a therapeutic PK. The smaller ones, when picked up early, responded well to the antibiotic drops. And like Dr. Prashant very, appropriately mentioned, that we are seeing an increased resistance to fluoroquinolones. So was our experience that, whether it is gadifloxacin, moxifloxacin, all of them were showing. So usually our protocol was to use a broad spectrum gadifloxacin post-operatively, which now we have also changed to chloramphenicol. And yes, we do start them on topical steroids. Usually it is the Lotepred or that we start in the post-operative period along with the bandage contact lens.
Dr. Shweta, you talked about this first case where you found a GPC later on, but this was also positive for HSV, if I understand, in the corneal half button?
No. That was the next patient.
Okay, fine. Yeah. And what is the choice of steroids you use in?
Loteprednolone.
Okay. And the frequency is QID?
We start with 4 times a day, and it is gradually tapered over weeks to once a day, and then it is stopped.
Thank you. Dr. Sangeeta, your comments on...
The outside, I'd like to congratulate Dr. Ashwini for this very nice presentation. And I must say that she covered almost A to Z, and many kudos to her guide. So obviously the college is preparing their students extremely well. I just had a few comments. I think everything has been covered between Prashant and Shweta. One was, I think this article was much the need of the day because we know that cross-linking is accessible and available to everybody. So we've all learned what precautions to take and what disasters can happen. I just had a few questions. There are a lot of surgeons who avoid putting a bandage lens. They prefer to patch, and that's what I did right at the beginning. But you have patients coming from outstation, and then you have to patch them every day till they heal. So eventually we switch to the bandage contact lens, but always with a fear. So we make sure that the patient stays in the city for 24 hours at least. And we watch the eye and make sure that the epithelium is migrating before sending the patient back. And the referring ophthalmologist is asked to see the patient every day till the epithelium heals, and the bandage contact lens to be removed with sterile forceps and not just with fingers. And in the preoperative prep, I think a lot has been spoken about the change in the antibiotics, but I think preparing the lid margins, making sure the lids are clean, there's no myomitis, and also there should not be any active VKC. Because I think one of the risk factors was an active inflammation or an allergic response, which could increase the risk. My question to Shweta is, what would have been the origin of the fungus? Were those referred patients, or what was the source? Was it contaminated drops? Because we can expect gram positive, gram negative, but the fungus was a bit of a surprise.
We also no idea from where did that fungus come. One of them was a referred case. One, I think, was an in-house case. But
right. So, if it was Candida, one can understand because you might have common sols, as Candida, but these were hyphae fungus, which was, so possibly the drops could be contaminated, or, what might be interesting to know which season the patient was operated. And about the steroids, what we do is we use non-steroidal anti-inflammatories till the epithelium heals, and then, hit them with full dose steroids and then switch to low dose steroids. So like Dr. Prashant said, it reduces the risk of scarring, but still we're really apprehensive. So is that a justified protocol, Prashant? Like we even soak the lens in preservative-free non-steroidal anti-inflammatory, like Rohit Shetty has been propagating, and it seems to work well for pain relief. I think one of the advantages of starting steroids day one is the pain relief. In fact, I had one of my patients who came back day two saying, his wife brought him in and said, it was so hard to keep him quiet. He said, it's hurting so much, I thought of killing myself. So that is the intense pain that a patient of C3R suffers. And so, steroids probably would work better than anything else. And that's why, since we don't use steroids, we just dose them, right up to midazolam or Restil, and we give them Ultracet and whatever, and just make sure they sleep out the first 24 hours. I've had patients coming in with bottles of proparacaine. And in fact, one or two of the infectious keratitis that we treated, the patient brought in a bottle of proparacaine that he'd been putting every 2 to 3 hours for pain relief. So, these are, I think, small things. And that's why I always look at the box of medicine that the patient brings in. So I just had one question for Prashant. The cultures were a methicillin sensitive Staph aureus and epidermis, Dr. Shweta as well. So where, one would have expected if they're resistant organisms, you would grow a MRSA, like a MRSA, especially those are the ones that are the hospital-acquired bugs that we see. So obviously these were common sols, and so I was also quite surprised. I would have thought it would be a resistant bug and you'd pick up MRSA instead of MSSAs. So
I think, Dr. Sangeeta, here, I think what happens in collagen cross-linking is there is apoptosis, immediate apoptosis. So I think the whole resistance or the defense mechanism of the eye is at bay because of the UV radiations are sterilizing, but I feel that the effect that the collagen cross-linking has on the cornea by causing an immediate apoptosis or something, it affects the entire corneal immune system to a way where I believe they all go into a state of, probably they're in a in a paralyzed state where it is the common cells which start acting, and you don't need something from outside to come and infect. It is just an immunosuppressed state, probably not the right word to frame it, but probably the immune system is at bay at that time because of the cross-linking effect on the cornea. And as far as you suggested about steroids and bandage contact lens, so in fact, after the first patient that I told you all that, my patient developed an infection and we had to take him up for therapeutic. So almost for 3 or 4 years, I have been only patching the eye with ointment till the defect healed, because that scar was so bad in my heart and my mind that I refused to put a bandage contact lens, thinking that that is the main culprit and the steroids. So I used to patch the patient, follow them up for 3 days, remove the, replace the patch every day. After 3 days, once the defect healed, then I would tell them, okay, boss, now you go home and you start everything. But over a period of time, when we saw that, probably that was one odd case, we started putting the lens and the steroids and the antibiotic again, and touch wood, things have been good. So I don't know, Dr. Prashant, your take on that? Why you think that we got the commensals as the main culprit?
No, so these are these are very similar in any kind of post-surgical infections. If you look at even the endophthalmitis, most common causes in endophthalmitis are gram-positive organisms. So they definitely come from either nasolacrimal route through the infected nasal flora or from the conjunctiva and the lid margin. And I think if you are performing a procedure, that's the first organism that attack. I will rather like to reserve my opinion on whether the UV light is sterilizing and that can really protect you from. I think ocular system and the human tissues are a very complex ecosystem. It is not just the natural defense system, but also the how the body responds and the vulnerability of each individual that matter a lot. So yes, UV light has its own advantages, but presuming that UV light is going to sterilize everything is taking that argument too far. Using corticosteroid, I think this debate is very common, particularly if you have burnt your fingers one, you become extremely careful and take the path on the other side. But I think any surgical trauma, um, anywhere on the body, is always associated with inflammation. How you approach post-surgical inflammation is an individual approach based on under what mentorship you have grown, what has been the philosophy of your alma mater, all of that determine. I have never hesitated to use corticosteroid where it is indicated, and I have never ventured into using corticosteroids where the use is not required. And I think that clarity, which is a correct approach, which is not correct approach, we can keep debating. That debate will be endless. So till the point that I was doing these procedures, I always have used bandage contact lens. I have always started corticosteroid, but I think in last 7, 8 years, I have treating more of complication, but not doing these procedure. So I don't know what the right approach is, and um, but I have always been in favor of that steroids are required both to control inflammation because you have to keep inflammation under control in these eyes where the cornea is relatively clear. And every bit of inflammation or prolonging inflammation is going to cause scarring. So uh, uh, I do not want to push too hard on that corticosteroid should be given because as I told, there are two schools of thoughts on this philosophy. If you feel that in my hands, I want to delay till epithelial healing has been established, is absolutely correct approach. The inflammation is not something that first day itself it is going to kill the corneal tissue. And if you are of the view that I want to start on the day one itself, you are also correct. So I think to summarize what the question you asked, most of these organisms are usually commensals, and that's where the first, whenever you have a breach in the defense system, they are the one which are present directly on the surface. Number two, that corticosteroid uses, people have different views, different opinion, but as long as you are convinced about the approach you want to take and you are consistently practice, there is no harm in it. The third is that bandage contact lens. They are good tools because at least there is you can see them carefully. A bandage contact lens since the time I joined LVPI, I have never used inpatient of keratitis or so. And once we started doing um, topical phaco, that also. So if you ask me in last 4 or 5 years, how many patients have been on putting bandage or adhesive, other than keratoplasty cases, I have never bandaged eyes. So I feel more comfortable with contact lenses. But I think these practices, we cannot argue or debate on these things. These are all individual. There is no science behind it. It is a belief. And I think each belief has their own background, and they are right as long as you are not seeing increase in the risk of problems.
Thank you, Dr.
At,
Prashant. Go to
at this point, if we are not short on time, we-
on the study design by Dr. Sengupta, and then we'll carry out our.
sure.
Yeah. So, Dr. Sengupta, are you around?
So sir has messaged and spoken to me right now. He's stuck in some work, so he will be unable to join right now.
Okay, fine. So then we can
Go ahead with the question. So I think we should just take time to differentiate how one should differentiate between a sterile infiltrate and a possible infection, right? So we know that a patient will be more symptomatic, but if he's on steroids, again, the symptoms may be subdued. But the local signs are what we would look at. And in staph, we know we won't get that purulent discharge like you get in gram negatives. But looking at that infiltrate, if it is fuzzy, if there's chamber reaction, and in the infiltrate starts looking a little yellowish, we know it's infective. And what I've observed about sterile infiltrates is they look more like whitish. The eye is quiet, and many times I've seen these infiltrates beyond the edge of deepithelization. So, literature shows that it's an immune response to the staphylococcal antigen. But I just wanted to know what your thoughts are on both these, Dr. Shweta, Dr. Parul. The occurrence of sterile infiltrates in an area which you have not deepithelized, and still those show infiltrate. So is it just the lymphocytic infiltration that is forming in little foci and these sterile infiltrates appear, or is it that there are bacteria against which there's a local response and these disappear with steroids in 48 hours?
Who wants to answer
Any
first?
thoughts?
Okay. So obviously, when we see these cases in the initial post-op period, so typically, I think if I see a patient where I see that there are multiple infiltrates in the periphery, I call them similar to what we see in marginal keratitis. So what you said is right. It's an hypersensitivity to the staph aureus antigens. So when you see an infection, I think infections are more severe. So one has to differentiate the infections from inflammation. So when you see the associated a lot of edema, a lot of anterior chamber reaction, I think one should err towards the infection rather than erring towards the inflammation. Because I've seen a couple of general ophthalmologists who would see these patients and they would still ask the patient to, keep putting the steroids. Because the general norm and general understanding is that in post C3R, if you see an infiltrate, it's more likely to be it's inflammatory and not more of an infective. And then we land up these patients with complications like perforations and therapeutic keratoplasties. That's my take. Dr. Prashant and Dr. Shweta. How would we differentiate? So you're muted.
Let Shweta speak.
Okay.
We learn from her also. And
We would love to listen to you, sir. So I can start and then you can correct me. Yeah, so I think in addition to whatever Parul said, I think the location also, usually the immune infiltrates would be more in the periphery. Suddenly having an immune infiltrate bang in the center would be less likely. But when you are dealing with collagen cross linking, it could be a possibility, but I think that would be a little rare. And also, I think the necrotic the stroma also would be like Parul said, the reaction would be severe. So I feel the stromal necrosis also would set in a little early. So if you're seeing not a very healthy stroma, too many peripheral infiltrates, it would be more towards a sterile. And I would still feel that, if in doubt, scrape. If in doubt, just scrape. It doesn't matter. If even if it turns out negative, at least some information you will get out of the microbiological scraping. So I personally believe that if I have a doubt, I would just go ahead and scrape the patient.
No, I think you both Sangeeta and Shweta covered and Parul covered the differentiating point. But let me tell you my experience, because I have managed possibly equal number of cases whom I have treated with corticosteroid because they were post C3R infiltrate rather than infection versus infective keratitis. At times, the distinction become very, very challenging. And therefore, I think the last sentence that Shweta, you mentioned, that whenever you have a suspicion, please err on the side of considering infective. Do corneal scraping. And if corneal scraping is negative and you have given antibiotic for 3 days and there is no response to therapy, at that point of time, you possibly need to revisit and review. Second scenario where you have to suspect against infection is where the patient has received treatment but has deteriorated despite receiving treatment and culture is negative. The best strategy in those cases, rather than changing antibiotic, stop all antibiotic, stop all NSAIDs. Give just lubricating drop and cycloplegic and observe them for another 2 days. And you will find that with removing all the noxious chemical that you are putting on the eye, many of these patients become very comfortable if they are of non-infective etiology. And that's where your diagnosis is established. After that, the approach should be promote epithelial healing. And once you see a good response on epithelial healing, put them on corticosteroid, and you will definitely win in that battle. So to summarize, it is very easy to debate about what are the clinical signs and other thing, but post C3R, I have seen patients who are non-infective but presenting with multifocal infiltrate. I have seen cases which are associated with hypopyon. I have seen patients which are having a melt central ulcer. In early cases, yes, there may be more clues for you to really identify infective cases. Particularly if you see there is a diffuse infiltration, then you know that you are possibly looking at non-infective as compared to where there is a dense localized infiltrate, which is more suggestive of its infective etiology. The second scenario where the infective etiology take precedence over non-infective is if you are seeing delayed infiltration. Like what Shweta described in first case, when the epithelial healing has happened, why should there be an infiltration? That means there is something that is infective etiology. And this is particularly important because the epithelium never becomes good for at least 6 weeks and is still vulnerable as far as any infection is concerned. So I think those are 2-3 points. Patient coming early, possibly you may be able to use these various signs described by others. But if the patient has been treated and is not responding, don't just keep on modifying therapy or switch them onto the combination of antibiotic, antifungal. That's not the correct approach. Rather, stop all the drugs, observe the patient for 2-3 days. And I was trying to pull a picture of one of the patient who came to me from Bangalore was on all kind of treatment for almost 10 days. And we stopped all the drug. He started becoming better. We gave a steroid. Finally, he ended up with 612 visual acuity and was very happy. And the clinical picture was 2/3 of the cornea infiltrated badly. I'll try to see if I can pull that picture and then show you. While we say that we can differentiate, we possibly will not be able to.
Dr. Prashant, I have a question now about reinstating steroid. Okay. So, unlike in our routine infections, corneal infections, we always say that you should have a culture positive, you have an antibiotic sensitivity in your hands, and you will only start when you see a significant amount of healing. But in cross-linking, my experience has been totally different. So if I start an antibiotics and I see that there is a response, there's a lot of amount of necrosis or stromal melting that you see in these patients with cross-linking. So we have to start a stronger steroids much earlier. So I would start even as early as 48 hours. I'm scared to start sometimes, but I start. The moment I start, I see a phenomenal improvement in the clinical response in these patients. You have a proven smear positive case and you see some response of the infection, but you don't see that it's responding the way a normal infection would respond. And you start a steroid and they just do, dramatically they improve. So what is the experience of the panelists? So should we really start steroids in these patients without our culture positivity and or not be?
I wouldn't.
Okay. Because most of my patients, wherever I've had in 3 cases and all, I had to start on steroids. And probably I could salvage them without having to go through, keratoplasty. One definitely needed a keratoplasty because there was an infection which presented. The general ophthalmologist kept asking the patient to put steroids, and there was a subtotal infiltrate, so it was impossible to. But still, I could manage conservatively. But there also we needed steroids, and a very very early institution of steroid. I know the experience of the others.
Is there any role of oral steroids?
I've not started on oral steroids. I've started on only topical steroids. So,
Especially if if I could have shared one of them, she came with like almost subtotal infiltration, like way beyond the area of cross-linking. Plus, there were satellite lesions. And, she came with a prescription of antifungals and all. And like Prashant said, we just stopped and saw. And initial scraping was nothing. Culture grew nothing. Then the third scraping showed some staph. But, she took like 3 to 4 weeks to heal with intense vascularization. In fact, this patient at one point developed choroidal effusion and hypotony, and that's where I had to give her oral steroids. And I thought this eye is going to shrink. It was so intense, the inflammation. So when you say that the inflammatory component is strong, this is what I saw, So it didn't just cause the cornea, but iritis, and she had choroidals which were picked up on ultrasound. And at that point, we gave her solumedrol, oral steroids, and slowly the whole thing subsided. And a year later, when the eye was stable and we repeated the ultrasound, the choroidals had gone, the intraocular pressure was better. I could do a corneal transplant. And today, that girl, she's like almost 7 years post-transplant, is still good. So, I mean, the inflammation can be as strong as that. So, I don't know whether it was just a cascade that started off with the cornea, ended up with the posterior segment, or it's really bizarre. I should actually write up that case, but I don't have the ultrasound pictures. So sometimes, yes.
I just wanted to highlight another point is that we are in linking using UVA light, but the actual germicidal ultraviolet light is a UVC. So we usually think that the UV light which we are using is germicidal, but is apoptotic as we know. And the other thing is that it works more on the DNA based organism. So that's why fungal spore bearers may not be effective so much, where the UVA may not have so much that effect. And the other thing is it's only penetrating 300 microns of the tissue. So it cannot sterilize the environment completely of the surface. So definitely these are the points which came to my mind that we are using UVA, which is not that germicidal.
Point.
We have any questions from the other moderators, Dr. Deepa, Dr. Neeraj?
So, Parul, I have one question. Anybody saw reactivation of HSV? How often do you see that? Or it's not that common? I just wanted to know from the panelist.
I have seen one patient where we probably thought it was infection because the patient definitely responded to antibiotics initially. But as I said, we had to give steroids. And this patient had gone out of station, but had repeated inflammations in the cornea. So probably ultimately it turned out to be a reactivated viral infection. And Dr. Prashant?
No, I have not seen many cases which are reactivation. The possibility is with any procedure, even if you do not do procedure, person is vulnerable, they may develop reactivation with any. So I don't think so. I have seen many cases of or cases of HSV reactivation. Yes, there is a possibility. We should keep that in mind.
In your series, have you all done the viral studies also for these patients, or it was only the routine bacterial?
No, none of them had a history or a clinical presentation. So, and HSV was one of the factors that was excluded, previous history or. So we did not, and in my personal experience, I've not had a patient where pre or post the patient had an HSV. So, but like I agree that there can always be an activation, but because any treatment, anything can reactivate a virus. But I haven't had a patient who had an HSV history earlier and for whom I'm doing a CXL or developed an HSV later post CXL. I've not had that experience.
I had a question for the panel. It's basically about the preoperative antibiotics. Would you start just one day before, or would you start 2 days before, or is it okay to start on the same day? Can resistance develop within 48 hours? Because, there were some reports I read where, especially in the quinolones, they have described that within 72 hours, the bugs can develop resistance. So what is the optimum time to start the preoperative prophylaxis?
Everyone is starting preoperative antibiotics here. I am not starting. I don't know.
I start one day before. But...
Dr. Shweta?
We start one day before.
And what about Dr. Prashant? What is this thing in LVP?
No, we do not start antibiotics to these patients, but yes, pay attention to the
flora, the surface, yeah, the eyelids.
Maybe it would be a good idea to ask them to do lid scrubs and face wash
probably
2 days prior. So even for cataracts, you're not giving antibiotics 1 day prior?
No, for cataract I'm giving, but not for C3R or refractive surgery. I'm not giving.
LVP, they're not giving for cataract either.
Yeah. I was not giving it before, but somehow I think some of the predisposing, as we rightly said, that we sometimes miss out on the preoperative proper check. I've had.
We did a study looking at the prevention of endophthalmitis protocols in 10 Asian countries from the key opinion leaders, and we asked what the practices are. And I think we were very surprised that the practices vary from giving antibiotic more than 3 days before surgery to not giving antibiotic. Povidone iodine was the only factor which was common at all center. Some people were giving even intracameral, others were not giving intracameral. And last, in most of the East Asian countries, they were even giving systemic antibiotics. However, when we took this in context with what are the practices in, say, Singapore or Bascom Palmer, who have 3 different decades published 3 different incidence report. The incidence is way, way low in these 2 centers published series, and they do not give antibiotic preoperatively, systemically, and even intracameral injection only in patients where there is a high risk of infection. Those are those where surgery is prolonged, posterior capsular rent is there. So since then, we are not advocating overuse of antibiotics from that time. So for example, in my cataract patients, I do not give a preoperative, but I am really mad at ensuring nurses appropriately handling lid margin, povidone iodine. And then I start antibiotic and steroid on the same day as the patient undergoing surgery. Yes, I agree that I think if you have case of endophthalmitis, the trauma that surgeon go through in addition to patient, it really makes you, oh, if there is any protocol which says that this is a protective, you start using those protect. But the overall evidence is more in favor of ensuring you are isolating conjunctival adnexa from the surgical field and are paying utmost attention to asepsis during the surgery, as well as wound closure. And that is, I'm talking of endophthalmitis. And similar things apply to pterygium, similar thing applies to collagen cross-linking, refractive surgery procedure.
I think we are overshooting the time. But one last question, Dr. Prashant.
Piyush wants to say something.
Piyush wants to say?
His hand is up.
I've lowered my hand, and just as an addition to what Dr. PG said, I mean, we have literally followed all the rules that were laid down upon us at LVPI. But I just wanted to add that when we're talking about extended time of surgery, I think retina wins the game over here. And frankly speaking, we don't use intraoperative antibiotics, pre-op antibiotics. It is only post-operative antibiotics that we use in clean cases, other than patients with known infected cases. Those are the patients that we would like to use pre-operative or intraoperative antibiotics. Otherwise, I don't think that there is any role of pre-operative or intraoperative antibiotics, honestly speaking.
Sir,
Sir has already covered what is important, making sure that the adnexa, the conjunctival, the closure, these are the important factors over here. We don't, I don't remember the last time I sutured a sclerotomy, maybe many years ago. So frankly speaking, I don't really know if there is any role of preoperative or intraoperative antibiotics in clean cases.
Thank you, Dr. Prashant and Dr. Shweta. I just have one more question. So when we are talking about this allergy and keratoconus, sometimes we see that the ocular surface allergy is not so much, but you do their systemic allergic test like an IgE level, it's very high. So are these patients at risk for infections or for complications post keratoconus? I mean, your experience. I'm not sure whether everyone does IgE levels, but
So, Dr. Parul, according to the allergists, we recently had a very beautiful meeting done in Cochin where we had a huge group of the pediatric allergists who had joined us in that meeting. And they have stopped doing serum IgE because, like, that is a parameter which is not indicative of only an allergy. So there could be 101 reasons for which the serum IgE could be raised. And ocular allergy as such is a closed compartment, and it is not always associated with the systemic allergy. And we do have reports where the systemic IgE level could be absolutely normal and the patient could be a severe grade of VKC, and vice versa. Patient could be in 3000 of IgE with no ocular features of allergy at all. So serum or systemic IgE is something that we routinely do not recommend or do it. But if the patient has a persistent form of BKC or an allergy where we are not able to control the symptoms or the symptoms are very persistent, then we ask for an allergy referral where a complete evaluation is done by the allergist and they rule out if there is a systemic component and that needs to be taken care of for a better ocular control. So sometimes they coexist, and like allergic rhinitis is something which is very common and it goes unnoticed because everybody who, when you tear, your nose starts watering. So it's like a reflex which we think, and often it goes misdiagnosed. So if we have patients who have persistent symptoms where we are not able to control them, we always send them to an allergist for a complete evaluation. Having said that, the first and the most important thing when we take up the patient for CXL is making sure that the ocular allergy is under control. So there should be no activity, which I think we all practice the same, that the eye should be quiet. There is no active allergy as such. But these are patients, again, where we have to be careful about their epithelial healing post-op because you can have issues with epithelial healing.
Thank you. Any questions? Otherwise, Vaishal, over to you.
Oh, so it was really insightful to hear you all talk about the infective keratitis post C3R. Really, it was a treat to hear, and small points here and there. It was really, really great. So I ask Dr. Piyush Bansal to give the Thanksgiving. Do the Thanksgiving. Dr. Piyush.
Thank you, sir, for this opportunity. First of all, I'd like to thank our presenter, Dr. Ashwini Deshmukh, who presented very well. And this very important topic that we could hold a myriad of discussions. Dr. Deepak Kumar, as well as the mentor of par excellence, Professor Rekha Khandelwal, Madam. And of course, all of this discussion would not have been possible without our expert national faculty, Dr. Prashant Garg, sir, who is a teacher to so many of us, including me. And Dr. Shweta Agarwal, she has just so much to contribute, so much to share. Thank you, madam. And of course, our very own Dr. Sangeeta Wagh, madam, who has, apart from sharing, she always has the best questions. So she will question everything. And that is the thing that, leads us to question ourselves. And so thank you, madam, for being there. Now, all of this would not have been possible without the JC committee chairman, which is Dr. Vaishal Kenia, our chief coordinator, Dr. Parul Deshpande, our statistical expert, Dr. Sen Gupta, and our very own young brigade, Dr. Zain and Neeraj. So thank you very much for having this wonderful JC tonight. I would also like to acknowledge Dr. Shirish Durad, sir, the president of Maharashtra Ophthalmic Society, Dr. Veeral Shah, the secretary of Maharashtra Ophthalmic Society, and Dr. Shon Chinchole, the treasurer. Apart from our own BOA office bearers, Dr. T.P. Lane, sir, our president, Dr. Himalini Samant, Dr. Ragini Parik, madam, and Dr. Reshma Zaberi. So, and of course, thank you, Entod, for supporting all our endeavors. With this, I hand it back to Dr. Vaishal Kenia.
Thank you so much. And I thank the audience for patiently listening and joining us for this Journal Club meeting. It was very nice to hear you all. Thank you for accepting our invitation and joining for this Journal Club meeting. Thank you so much.
Thank you. Thank you so much.
Good night, everybody.
Thank you.